We're going to do dyslipidemias in children and adolescents. Dr. Pasierb and Dr. Miranda are going to present, and Dr. Pasierb has done her training at Rutgers and fellowship at University of Washington. And thank you so much for presenting to us today.
Okay. All right, guys. Well, it's kind of fun to be the last one between you guys to the weekend, right? So I'm going to try to go through these. I'm sure there'll be some questions, but as always, Dr. Miranda and I are always here for any questions that you might have regarding high lipids in pediatric patients. So going forward, I have no disclosures. And the goals of my talk today are really to focus on mechanisms of hyperlipidemia, universal screening versus risk-based screening, treatment and medications, and then a little bit about our lipid clinic, which we developed here to kind of serve the needs of this special patient population. So when we talk about causes, we're looking at three main issues: genetic causes, familial hyperlipidemia, both homozygous versus heterozygous presentations, versus secondary causes, which are usually endocrine or renal-based, and then acquired causes, including your metabolic state, obesity, diet activity level, medications that you're taking. And so throwback pathophys picture, if we look at familial hyperlipidemia, we're talking about our LDLR receptor as the primary driver. If you have a gene mutation within your LDLR, you're going to fail to bind LDL and bring that in to the liver, and that causes an increased hepatic LDL synthesis. And so gene mutations within that LDLR are an inhibition failure, if you will. We also have our ApoB, our PCSK9, and our LDLR AP1 gene mutations. And so if you kind of look at this cute little diagram, we have our LDL receptor on the hepatic surface. It'll bind your ApoB ligand on the LDL particle itself. PCSK9 is a degradation protein for breaking down LDL receptors. And then we have our LDLR AP1 protein that actually kind of positions the receptor in the right place to bring that LDL into the liver itself. And so mutations at any of these three genes themselves cause issues with how our liver is going to process, synthesize, uptake all of the fat that we eat, and also what our liver will do as it makes LDL. And so when we talk about homozygous FH, we're talking about true homozygotes versus a combined heterozygote. And this is, again, quite rare, 1 in 300,000. Our LDL levels tend to be above 400. And this presents itself with premature coronary artery disease within that first decade of life. The physical exam is usually quite marked. You're going to see xanthomas in childhood. You may hear more of an aortic outflow murmur due to some supravalvular stenosis because of atherosclerotic plaques. They can also develop in the carotids and the renal arteries. And this requires aggressive medical management in addition to LDL apheresis. Heterozygous FH, which is something that we're really trying to target with our lipid clinic, is an autosomal dominant mutation within one of those three main genes. The prevalence is anywhere between 1 in 200 to 1 in 500. So much more frequent than you would think, and we're starting to pick it up much more frequently since we're screening more. The phenotypic LDL levels usually range greater than 150. They have a normal physical exam, and in this case, early treatment with statins often helps to reduce the morbidity and mortality associated with it and bring your risk of early cardiovascular disease closer to the general population. And so just a diagram that shows you the difference. If you have a FH mutation, you're going to be that dark blue. And again, you're presenting with LDLs that are much higher. Your mean is going to be somewhere in the 190s. Versus without a mutation, so either a secondary cause issue or some of the polygenic ones that I'll mention shortly, you're going to have a lower mean, somewhere within the 130s. And so polygenic hypercholesterolemia is something that we're learning more about. So if you do not have a mutation within those 3 main genes, it's usually going to be related to mutations within your single nucleotide polymorphism, so kind of multi-little variants. And so these patients still require treatment with statins and lifestyle modifications because their risk is higher for cardiovascular disease as they get older. Secondary causes of hyperlipidemia, I won't go through all of them, but again, we're dealing with endocrine disorders, we're dealing with pregnancy, metabolic disorders, kidney disorders, liver, infectious. So again, if you obtain a lipid panel during an acute infection, expect some derangement. Inflammatory processes, medications such as steroids, beta blockers, OCPs, chemotherapies, those are all important to know. If you have a patient who is an alcoholic or has a lot of issues with intoxication, that'll be, acute intoxication will also drive up your numbers, and anorexia nervosa as well. And then our third cause is often metabolic or obesity related, and that's a trifecta of your lipid panel derangement where you have low HDL, high triglycerides, often somewhere up into the 200, 300, 400s, and mildly elevated LDL levels, somewhere between 120 to 140. And then when we talk about differences in these LDL levels, these LDL particles are a little smaller, a little more dense. So if you really got to the nitty gritty, there is ways to kind of parse that out and try to figure out what's going on. Some of these patients, however, are going to be kind of that complex combined where they also have familial hyperlipidemia. The primary treatment for your metabolic patients is lifestyle modification, which is going to be increased exercise, child 1 and child 2 diet modifications, which we'll go through later, as well as treatment with a statin depending on the actual levels that they are at, and how successful you are with lifestyle modification, and whether or not they have additional risk factors. And I included the entity of hypertriglyceridemia. This is much more rare to be a familial hypertriglyceridemia, but your levels are going to be greater than 1,000, which increases your risk of pancreatitis and necessitates treatment. And likewise, there's 2 main mutations that we're aware of, both the LPL deficiency, which is very rare, 1 in 500,000 to 1 in a million, versus an ApoC2 mutation with loss of function. And so those things, again, are going to cause markedly elevated triglycerides. And I put a little line down here that talks about non-fasting tests, because oftentimes that first screen that we're doing is a non-fasting lipid panel, and our triglycerides may be elevated, but they're often less than 500. And so one of those things to be aware of when you order these. And some of the newest, I guess, hot topic for lipids would be lipoprotein A. And so lipoprotein A is an interesting risk in and of itself. So it's a glycoprotein that's similar to plasminogen, and it increases the adherence of LDL to your blood vessels. And so this is an independent risk factor for coronary artery disease. If you have elevated LPA, it's kind of a genetic predetermined risk. And that actually will increase your risk for pulmonary vascular disease, peripheral artery disease, and even neonatal stroke. So in and of itself, an independent risk factor. When you have FH plus an elevated LPA, it pretty much demands an intensified treatment strategy, really tight LDL levels, trying to keep them within range because of your elevated risk. And so we're targeting something here that I would argue is the single most modifiable cause of morbidity and mortality in pediatrics. So we're trying to modify lipid levels to prevent premature coronary artery disease and familial hypercholesterolemia. When we talk about being genotype positive, phenotype positive, you have a 22-fold increased risk of cardiovascular disease compared to those who have no gene positivity. If you're genotype negative but phenotypically positive, you have a 6-fold increase compared to those with normal. So again, having that gene and those abnormal receptors and liver processing, if you will, put you at a markedly increased risk. So much so that by 50 years of age, 25% of women and 50% of men are going to have a clinical cardiovascular event. And then given the ease of diagnosis of this, the low risk treatment that we can do, and the excellent cost-benefit ratio that's been proven throughout the world, especially in countries like Norway, Netherlands, this is something that we wanted to stress today, that as pediatricians, we can all screen and really make an impact. And this is just a visual that shows you the difference. In the red is gene mutation FH versus in the blue gene negative. And you can see the risk, the odds ratios for coronary artery disease jump up much higher if you have the gene mutation, regardless of your LDL levels. So even up here, your LDL levels to the right of the screen might be greater than 200, 220, but if you are FH positive, gene mutation positive, your risk of coronary artery disease is quite high. And so this is probably the most poignant slide of the whole presentation. Here we're looking at homozygous all the way to the left, that blue line, if you will. Untreated homozygous FH is going to cause coronary artery disease and death before the age of 20. Heterozygous is that red line towards the middle. That's going to cause coronary artery disease before the age of 55 to 60 if left untreated. And then way down at the bottom, that kind of yellow-orange line is our normal general population. And so our hope is to, as pediatricians, is to really target, well, the homozygous is a little more easy to diagnose, but really target our diagnosis of heterozygous FH. And so when we look at that, if we start a low-dose statin within the age range 9 to 11 when we're doing our universal screening, we can actually bring that risk of disease or death down closer to normal, where you may have an incidence within 53 years of age or so. That's much better than even if we started later towards 18, 19. If we start a high dose statin, we still don't achieve that same kind of modification, if you will. And so the goal as pediatricians would be to target our 9 to 11 year screening to make sure that we capture this group, because we'll make the biggest change for this patient population by doing so and by starting treatment. And so I included a whole lot of references at the end that I encourage you all to peruse and really go through. But the 2018 AHA screening guidelines focus on selective screening, universal screening, and cascade screening. And I included their level of evidence and a recommendation, if you will. But selective screening for children should begin at the age of 2 years if you have a significant family history or significant hypercholesterolemia, and that's deemed reasonable. You should do selective screening in children with obesity or other risk factors. You should do universal screening in all children 9 to 11 years of age, and again, 17 to 20 years of age. And cascade screening is recommended for all family members of children with hyperlipidemia. If we dive a little deeper into selective screening for FH, we're talking about family history. So if you have a history of early cardiovascular disease, such as MI, angina, coronary artery disease, including bypass, stenting, angioplasty, or sudden death in your parent, grandparent, aunt, uncle, less than 55 years of age for the men, less than 65 for the women, that puts you at a higher risk, and you should be screened. If your parental total cholesterol is greater than 240, or they have a known dyslipidemia, you should be screening those kids, again, starting as early as 2 years of age. The support for universal screening comes from pretty much all the major bodies, AAP, AHA, ACC. The only one that put a little bit of a hard to conclude or recommend for or against was the USPSTF back in 2016. So one of our older studies said there's insufficient data to recommend for universal screening. That does not account for selective screening. So selective screening is a different thing. Right now, what we're using, which is best for our pediatric patients, is the US MedPed screening tool. And so that focuses on the age of the patient and whether or not a first, second, or third degree relative has qualified or is diagnosed with FH. And so if you look at that first line, if you're less than 20 years of age, which is our patients, and let's say your mom has known FH or cholesterol high enough to qualify for that own diagnosis for her, then your total cholesterol, you'll meet diagnosis if it's above 220. And you can kind of go along through and see if you have a second-degree relative, a third-degree relative, or if you don't know if that doesn't apply to you, if your total cholesterol goes above 270 general population, then you meet criteria for the diagnosis of FH. A little bit about genetics. So genetic testing is now considered the standard of care per the 2018 ACC statement. And so again, we're testing for LDLR, ApoB, PCSK9, LDLR, AP1, and I put the actual incidence, which causes what, and the LDLR is the highest incidence causing FH. And anywhere between 60 to 80% will have a positive genetic test if they meet criteria for FH, clinical FH. And I pulled this from that JACC article as well, and it really goes through the idea of what we're thinking. If you have a patient that's at risk due to family history versus a patient with a phenotype, we're thinking cascade testing versus gene-specific testing. If you're gene positive, phenotype negative, we're often monitoring you. If you're gene positive, phenotype positive, we're often treating you. If you're gene negative and phenotype positive, it's a little bit of both. It really depends on what's causing it. And so again, we're going through polygenic mutations, weighing that. We're looking at your LPA, weighing that. And there are so many other genes that are still unknown that we're still working on better ways to diagnose, if you will. The benefits of genetic testing, even in our pediatric population, is really to confirm the diagnosis, establish a lifetime risk, cascade testing, catching more children, throughout the family, if you will, improve treatment compliance, optimal treatment strategies, more aggressive lipid lowering. So we really try to tighten up our LDL levels and really target LDLs less than 100. Psychological benefit, and the limitations of genetic testing usually include cost, although that is changing. It's becoming much more affordable, even out of pocket, and more of our insurance carriers are covering it. And the results may be inconclusive, and so another limitation if we're getting more of those VUSs or uncertain variants where we're not sure whether or not this would be pathogenic. This table is coming from the 2019 circulation. So this is probably one of the more recent publications regarding risk stratification, if you will. And so identification of increased risk warrants yearly lipid screening. So if you're in the high risk category, which is either homozygous FH, type 2 diabetes, end-stage renal disease, Kawasaki disease with persistent aneurysm, if you've had a solid organ transplant, if you are a childhood cancer survivor, that all puts you at higher risk and you warrant a yearly lipid screening. And that's something that I think as pediatricians, we all could do more of. In terms of moderate risk, if you're severely obese, if you have heterozygous FH, hypertension, coarctation, LPA, all those things, that's going to be at moderate risk. And then you can see the table at risk in terms of if you have fatty liver disease, other cardiomyopathies, pulmonary hypertension, rheumatologic conditions, those all also put you at risk. And you should be screening these patients yearly. I copied and pasted this from the ACC 2018 guidelines, more for you to review at your leisure. It goes again just to really reinforce what we're talking about, what we're doing in terms of both lifestyle modification, in terms of screening, in terms of cascade screening, and then also for our metabolic or more obese patients, again, screening and continuing to do lipid profiles for them. In terms of treatment, we're talking about two different things. So if we're targeting triglyceride versus if we're targeting LDL. So targeting triglycerides, we all kind of know this, low carbs, exercise, weight loss. We could use fiber and acid agents, fish oil. If we're targeting our LDL, we're talking low-fat diet, exercise, weight loss, statins, or ezetimibe. When we talk about diet, I put these here so that you guys can have them as well, but our dietitians will usually review child 1 recommendations and child 2 recommendations with the family, and we're targeting total fat intake, cholesterol, servings of fruits and veggies, fiber, decreased refined sugars, and then again avoiding extra fats through low-fat dairy and avoiding sugared beverages. Versus child 2, which is a little more stringent, again, both in the total fat, the cholesterol, the fiber intake. And so those are our 2 mainstays for diet recommendations. I get a lot of requests from pediatricians for that, so I included them in the slides just for you to have as a reference. And I also included normal and abnormal lab values. So again, when we're talking about total cholesterol levels for children, triglyceride levels, HDL, LDL, it's really important that the lab that you use follows kind of these reference ranges. And oftentimes what I've seen is if the actual result is reported out with adult criteria, the LDL levels aren't flagged. And so it's important to kind of have a cutoff in your mind of where your pediatric LDL levels should be. And again, our acceptable would be less than 110 for children. We focus on patient education, educating on appropriate portions, healthy eating, family-based changes, limited screen time, daily activity. And then in terms of medications, it's reasonable to begin statins after a 3 to 6 month trial period of lifestyle modifications. So that's both the activity, the diet, the exercise. It's reasonable if after doing that for a good 3 to 6 months, if you're unable to see those LDL levels come down, to start statins. And so for the most part, the majority of the statins that we use, if you are 10 or older, if you have LDL levels greater than 190, 160 with clinical FH or high risk factors, or greater than 130 if you have 2 high risk factors, those are all indications to start medications. And when you start a medication, you actually expect somewhere between a 30 to 50% decrease in your LDL, whereas lifestyle modifications alone will give you 5 to 10. Now, a combination of both is obviously optimal to really help drive down LDL levels. And so even just starting a child on statin, we still push for healthy eating habits and exercise. Common statin side effects. So we have GI side effects, probably the most common. The most common one that I've seen personally is more abdominal cramping. There can be some arthralgias and myalgias. The serious side effects to be aware of would be dermatomyositis, elevated ALT, and probably the most well-known is if you have rhabdomyolysis from statins, which is very, very rare. Statins in pregnancy. So statins are contraindicated in pregnancy. So I usually begin counseling families about this early, even pre-menarche, if you will, and then counsel a little more in detail about contraception in post-menarchal females. So somewhere in that 12, 13 age range, definitely starting that conversation about contraception. The use of oral contraceptives is not contraindicated if it's medically appropriate. So you can use contraceptives if you're on a statin. It's recommended to do so. And in terms of lab monitoring, I have questions, a lot of questions in terms of, well, what do we order? So that initial universal screening, the fasting lipid panel, follow-up universal screening, the fasting lipid panel after a trial of diet and exercise. Selective screening, at that point, if you have concerns for FH, we're oftentimes wanting to rule out secondary causes. And so you'll see me often order a TSH, a CMP, hemoglobin A1C if there are concerns for obesity and possible insulin resistance, a urinalysis, and another fasting lipid panel. I've had a few patients who have had markedly elevated LDL levels because of hypothyroidism, because of uncontrolled type 1 diabetes, as well as chronic kidney disease. On statins, once they're on a statin medication, we're really following their hepatic function as well as their CPK, and fasting lipid panels to make sure that we're actually bringing down that LDL, and we will titrate that statin dose often monthly. Once at steady state, we usually follow them every 6 months. If we do see side effects such as myalgia, we would repeat a CPK looking for any kind of rhabdo issue, and that would be concerning if your CPK is 10 times above the upper limits of normal, again, taking into account any specific physical activity, so whether or not they were weightlifting beforehand. Our Sanford Lipid Clinic is a treatment team consisting of pediatric cardiologists and our nurse practitioner, genetic counselor, dietitian, exercise physiologist, and an integrative health therapist. And so to accomplish everything that I just laid out on the slides beforehand, we need to be able to assess for the diagnosis. Is it genetic? Is it a secondary cause? Is it an acquired cause or metabolic cause, medication cause? We need our genetic counselor.
Happy New Year to you. Good.
To kind of dive deeper into the family.
Okay. Thank you.
And in terms of our dietitian, they will often go through that child 1, child 2. Our exercise physiologist will really work on age-appropriate exercise recommendations, ways to increase movement and decrease screen time. And our integrative health therapist helps both with the difficulties of kind of accepting a diagnosis, beginning treatment early, compliance, the stress that kind of goes along with that, especially in our teenagers. Overall, from September 2019 to present, when we kind of combed our data, we've had 33 patients who've met criteria for treatment. And this is over the span of about five to six of our lipid clinics. We've actually had 33 patients who meet criteria needing statin medication. 27 of those met the US MedPed criteria that I went through. 10 of those underwent genetic testing, with 9 being positive, and 15 of those patients are on statins. The cascade testing from that resulted in 3 families in which we identified an additional 4 patients. And so, this is something that pushed Dr. Miranda and I to really want to increase the universal screening that we do as an enterprise here at Sanford. And so, looking at our numbers, our 2019 to 2020 data, if you will, we saw about 3,700 well-child visits between age of 9 to 11, and we ordered 700 lipid tests just as a pediatrics, if you will, department here at Sanford Fargo. And so just that number, with some of the interventions that we've done over the past year, we've actually increased our overall compliance at screening up from approximately 4% to closer to 12 to 19%. Now, this is raw data. There may be some duplicate lipid tests in there from the start of the lipid clinic, if you will, kind of our raw data, but just something encouraging to see that as we continue to educate and advocate for more screening, within our own providers, we've seen an increase in those numbers and compliance in terms of screening. And this is just a screenshot of our data set that we're collecting. And so that top half of the data shows you some of the highest LDL levels I've ever seen, the highest one being 340. All those patients within that top half are on statin medications, are gene positive. The lower half, that's kind of more of the mixed picture, if you will, where their LDLs aren't quite as high, but they might have a significant family history, and we're still kind of trending them and trying to make changes with lifestyle modification. But it definitely shows you that kind of dichotomy. Once you cross over into high LDL levels, your likelihood of being gene positive is quite high. And so these are the references that I, again, recommend that you all peruse and really go through. It's something that I think is important that we kind of master. I think it'll make a big difference, knowing that cardiovascular disease is the #1 killer in the US generally. if we can target it as pediatricians and make changes treating particularly patients with familial hyperlipidemia, we can actually make a big difference. And so thank you everyone for everything that you do, and our emails are there for anyone who has any questions, patient cases they want to run by us. We're always happy to discuss.